privilege to give a presentation today, but I have a huge stage fear, talking after the Rick and Professor Wallimann and Uwe Schlattner in the first row, so it's not easy for me to really have this opportunity. Can I have a... Okay. I'm going to give an update or something that actually was presented 3 years earlier at a conference in 2022 about creatine for chronic fatigue syndrome. But in the meantime, with the COVID pandemics and stuff, it appears to be really interesting and relevant because most of the important papers and studies has been conducted in the past 3 years. This is just my disclosure slide, and today I'm going to talk a little bit about the background, what is chronic fatigue syndrome, which is really interesting, kind of mysterious and perplexing condition. I'm going to give some general scope of the problem to see that it's not just something that is way off after the COVID. It is present almost every single day after we suffer different viral infections, but even if not, there is some non-viral contributions to the contributors to this problem. I'm going to give a very interesting fundamentals on chronic fatigue syndrome because we do not know a lot about this condition. How this condition might affect the creatine metabolism. It is a long story actually. So many different studies try to understand what's happening with the creatine metabolism during the chronic fatigue syndrome. Can creatine be helpful in this condition? It's really interesting that although we have so many people experiencing post-viral fatigue syndrome, very few studies using creatine actually has been conducted in the past to analyze the effect of this important nutrient. Many open questions, and also to bring something to your home and think about it further. This is just an overview of the chronic fatigue syndrome or myalgic encephalomyelitis or long COVID. You could see here that over 48,000 papers has been published, but most of them concentrated through the past 5 years with the long COVID. And if we just go into the review papers, you could see here that for the year 2021, almost 12,000 papers has been published. And if we switch to the research papers only, you could see here more than 8,000 papers with 1,900 research papers in a single year, meaning you have to read 3 research papers every single day and almost 10 review papers every single day, you know, to understand what is going on with this very interesting condition. What about chronic fatigue syndrome in terms of the literature? You could see here we had 2 journals dedicated to chronic fatigue syndrome. One is defunct at this moment. Many special issues or chronic fatigue syndrome from many different journals and publishers in the past 20 years or so. Couple of books dedicated to chronic fatigue syndrome, and this one is also illustrating, you know, the problem for the rest of us, piece of the reference, chronic fatigue syndrome for the dummies, and I've been considering a dummy myself, you know, because we still don't understand what is causing the chronic fatigue syndrome. We don't have any gold standard biomarkers, and we don't have cure. So many books and so many papers here, and we are still at the beginning of the problem. You could see here that at the dawn of the long COVID syndrome, New England Journal of Medicine, one of the most influential journals in the field of science in general, particularly in the medicine, suggested that it might be a big problem. So the COVID was all over the place, but the long COVID has been suggested to be an even bigger problem than the COVID itself. And the newest one, published approximately 9 months ago, suggested in New England Journal of Medicine to think over about the criteria, how to recognize and define this perplexing condition. So chronic fatigue syndrome was all around the place for many, many years, but with long COVID, actually the highlighted information has that put a new light on this old old problem. This is a really interesting slide. It's not coming from the scientific literature, but from Harvard Business School. David Cutler and his colleagues estimated the costs of the long COVID a couple of years ago. In 2020, JAMA Viewpoint, they calculated that the numbers are 2.6 trillion. And they changed the calculation, but it's not really the whole sum. The whole sum calculated a little bit later, I think it was in late 2024, it was 3.7 trillion in total costs, including direct and indirect costs. Another information that provides a background for chronic fatigue syndrome or ME or long COVID, actually is the same. It's really interesting information coming from the NIH. Back in 2021, 1.15 billion has been awarded to the big initiative called Recover COVID. And in 2024, about a year ago, NIH bolstered the money to understand this perplexing condition with additional 500 million. So this is a pressing issue. This specific project has 3 different parts, suggesting that it might be a really, really important to understand in terms of the cost, in terms of the prevalence as well, to understand what appears to be the problem, not just behind the disease, but also to understand it better in terms of diagnostics and eventually to find out what would be the possible cure. Another important information about the background of long COVID or chronic fatigue syndrome is plenty of different patient-related societies that try to help people and consumers and patients to understand this condition. This is just a short list of the most popular or relevant association, including the International Association for Chronic Fatigue Syndrome, American Myalgic Encephalomyelitis, Chronic Fatigue Syndrome Society, SOLVE Chronic Fatigue Syndrome Initiative, Long COVID Initiative, Chronic Fatigue Initiative. In Massachusetts, Myalgic Encephalomyelitis Society. In Britain, ME Association, and many, many others, organizing patients to help them really to understand this disease and to help them how to, not exactly to cure it, but to treat it whatsoever. And actually everything started in a small island of Iceland many years ago in 1950. It was a really interesting story, and it was the first paper that actually depicted something that appears to be present many years ago, but this is a first recognition of the disease. In the northern part of the island, in the place known as Akureyri, Dr. Sigurdsson and his colleagues find out a very interesting epidemic with about 465 cases. It was really interesting because these guys experienced something that looked like a classical flu, but it was a little bit different because they didn't find any really relevant classical indicators of infection of flu, but this unknown disease has been characterized by insidious onset of symptoms. And all the people have a kind of fatigue, particularly following even a slightest exertion, as well as many problems related with the brain function, such as disturbed sleep, concentration, emotional disturbances, and often the muscles were very tender to touch, along with some other conditions. Okay, we didn't understand that back in the day, but even more interesting, these guys evaluated the patient six years later. And they published a paper in a Lancet, and many of the patients, they still have similar problems, like a fatigue, muscle soreness, pains, and tiredness, and sleep problems, 6 years after the initial Akureyri disease called back in the day. So the Lancet decided to put this story even in write an editorial for this unknown disease, suggesting a new clinical entity, benign myalgic encephalomyelitis, and some people still use this name for the disease, without really understanding what is the cause of this mysterious condition. And up to these days, it remains for all research community to address the symptoms fully and also to propose a kind of treatment. Right now, at this moment, as a medical doctor, I am very confident to say this is a neurological condition. We have chronic fatigue syndrome or myalgic encephalomyelitis recognized in the ECD-11, the recent publication registering all the medical diseases. And this is 8E49 post-viral fatigue syndrome, which is the official name, but I will use chronic fatigue syndrome as well throughout this presentation. And, but still, people don't recognize it as a neurological disease because the main characteristics, main attribute, clinical attribute is fatigue. When we go into the information about the prevalence of this condition, you could see here that it really varies a lot throughout the many papers analyzing the prevalence of chronic fatigue syndrome, up to 7.6% of the whole population before the COVID pandemics. It appears to be a little bit more prevalent in women, a little bit more prevalent in adults, but the problem is that most diagnosis of chronic fatigue syndrome has been conducted by doing an interviews with the people more than clinician-reported outcomes, such as different kinds of tests. If you analyze the most critical elements of chronic fatigue syndrome, it appears to be cognitive impairment on one side, and on the other side, fatigue. There is plenty of other attributes of chronic fatigue syndrome. A few years after the end of the pandemics in 2023, WHO estimates the number of people who might suffer from long COVID, and they're going to suffer not just in a year or two, but many, many years upcoming, is up to 20%. So we are not free of long COVID yet, and we are not going to be free of the next viral epidemic, so it is going to stay with us for many, many years. So that is why we have to keep doing a research, including creating research regarding this condition. There is many criteria how to diagnose the chronic fatigue syndrome, but there is no best way how to do it, and this is just a kind of a summary of some of the guidelines embraced by the CDC, for instance. Typically, you have to develop the fatigue that is 6 months or longer, persistent and relapsing fatigue after the viral infection. Another important element is the post-exertional malaise that is lasting more than 24 hours, so people are not doing well, doing any kind of exercise, even going up to the stairs. Another important element is the problems with short memory and concentration. We call often that brain fog, and we often experience that after the viral infection. Sore throat, tender lymph nodes, muscle pain all across the body, unrefreshing sleep is also another one. But if you go into the guidelines, I'm just going to summarize it here. We don't know the cause. Is it a viral or a kind of autoimmune response to the viral? We do not have pathognomonic diagnostic criteria, so no gold standard test to say this person has a chronic fatigue syndrome, and no approved medical treatment. So I'm off. We don't know almost anything, but still we are facing, me as a medical doctor, I'm facing people who have chronic fatigue syndrome and they ask for a treatment, and there is no approved treatment. Similar thing goes with long COVID as well. It's a little bit different because people are paying more attention since so many people are suffering from long COVID, but basically it's exactly the same. Mostly it's a brain or muscular tissue, even heart. And of course, in long COVID, we have a little bit more problems with smell and tastes as well. But it's basically the similar. This is the paper I cited earlier about the long COVID, very important and influential. What we still know about the long COVID at this moment. There's a couple of viruses that definitely are linked to the long COVID, and we'll learn that coronaviruses are related with chronic fatigue syndrome many, many years, at least 2 decades before the COVID pandemics. This paper has been published in 2003. So we expected that the COVID pandemic is going to induce a lot of people suffering from chronic fatigue syndrome. But there is also other non-viral contributors, including the family history, immune system abnormalities, people who often have a sleep disturbance or disruption problems, they are more prone to having a chronic fatigue syndrome, psychiatric disorders. And energy shortfall might be one of the reasons why these people often have a long COVID symptoms. So what comes first remains an issue. With COVID pandemics and long COVID, after the pandemics, people try to discuss and describe any single possible etiological or pathogenesis factor related to chronic fatigue syndrome. And you could see here a very extensive list of different neurological, fatigue, muscular, renal, immune, respiratory system. And it's really interesting here that bioenergetic disorders might play a role. So people who are not into the creatine research community, they recognize there might be a problem with mitochondria, and there might be a problem with providing enough high phosphate energy resources for this disease. On the right part of the slide, you could see plenty of different biomarkers, hundreds of different biomarkers tested during the past 5 years to see is there any sensitive enough to discriminate people between long COVID and healthy people. Many are biochemical, cytokines, neurological markers, vascular markers, many others, and still we don't have a gold standard test. Maybe because we didn't involve the creatine in the whole story. So this is a highly influential paper on long COVID. It's published in Lancet some time ago, and it's actually very complex. I'm not going into the details, but besides the vascular damage, this is definitely one of the reasons why people suffer from after the COVID, why people suffer from long COVID. So there is a vascular component as well as the hormonal imbalance. Mitochondrial dysfunction might be one of the critical elements that actually make some people prone to the long COVID. This is very important in terms of addressing the biomarkers, possible biomarkers of long COVID, but also to understand and conduct different clinical trials that will focus to different interventions that might affect vascular damage or hormonal disbalance or eventually mitochondrial dysfunction. So is a place for creatine really into this from the point of biomarkers and diagnostics, but also as a possible therapeutics? Actually, many, many years ago, people start to analyze, is there any disturbances in creatine metabolism regarding the chronic fatigue syndrome? And you could see here, of course, one of the surrogate markers of creatine metabolism is the level of creatine kinase in the blood, simple, cheap, and stuff like that. And most of the studies didn't find anything really different. Typically, the level of CK were normal, a little bit elevated in some cases, but no big deal. But what appears to be really interesting is that still, even 20 years later, after suffering chronic fatigue syndrome, we still find some traces of the enteroviruses RNA in the muscle, specifically in the muscle. It's really, really interesting that there is no study, at least when I did analysis of literature, analyzing the level of creatine in the blood. So nobody did that. This is just a list of the studies analyzing the CK levels, and it's not a big deal. This is one interesting case of high levels of CK, but probably not related to creatine metabolism by itself. But of course, it's a much better marker of cellular destruction than creatine metabolism. Of course, we get some knowledge on creatine metabolism in chronic fatigue syndrome with introduction of magnetic resonance spectroscopy analysis. And I'm going to show you some interesting data on muscle, but also some other tissues as well. First studies didn't find a big difference in creatine metabolism or PCR levels, but they noted a lower levels at ATP after the heavy exercise and at exhaustion level. But other studies also find a little bit different levels of PCR during exercise, including the pH levels in the muscle, or reduced level of post-exercise PCR resynthesis after the end of the session inside the muscle. And finally, the study in 1998 found decreased resting CR to PCR ratio. So definitely these introductory studies suggest there is a kind of disturbances, but we are not really sure the type of the response to long COVID, because most of the studies actually analyze the ratios instead of analyzing the absolute levels of creatine in this critical organ. Besides the muscle, we also notice the disturbances in creatine metabolism in the brain as well. We find, the researchers find reduced levels of creatine in some parts of the brain, particularly in hippocampal creatine in people suffering from a long COVID back in 2000. And also many of these studies suggest that might be a change in creatine levels, although they still didn't report the level of creatine in absolute levels. Instead, they're using different ratios, particularly choline to creatine ratio. So either creatine is decreasing or choline is increasing with these results, but still we noted that in different cohorts of chronic fatigue syndrome patients, including the children, and also in people suffering from hepatitis C who are also having chronic fatigue syndrome. So this is a nice depiction of the last study. I think the choline to creatine ratio appears to be significantly affected by the chronic fatigue syndrome, suggesting that it might be really a creatine that is an important part of this formula. But it's really interesting, not just the typical muscle and brain magnetic resonance spectroscopy analysis suggesting the creatine might be impaired. It's also in the heart. This study analyzed 12 patients, and we noticed the mean PCR to ATP ratio tended to be lower. 33.3% of patients had levels consistent with cardiac impairment. So people not often consider long COVID or chronic fatigue syndrome as actually a heart problem. So these guys might face a very serious condition. Reduced maximal initial protonal efflux rates were also noted. You could see here a difference in PCR to ATP ratio between CFS patients and control. And again, in the heart muscle, the half time for PCR recovery appears to be prolonged in long COVID. This is not the end of the story. It's really interesting that not just these objectively measured assessments are relevant, but if you correlate it with the disease severity, you're going to see the lower the creatine level, the higher or more severe condition. So the nice study with almost 90 women suffering from chronic fatigue syndrome suggested that more pain in chronic fatigue syndrome was associated with reduced gray matter volume and impaired N-acetyl aspartate to creatine ratio in the some specific components of domains or areas of prefrontal cortex. So this is the first study known to me as doing an analysis of literature, suggesting that there is a link between the clinical symptoms and the level of creatine, indirectly level of creatine in the brain of people suffering from chronic fatigue syndrome. This is also confirmed in a series of studies analyzing the level of creatine or the ratio between choline and creatine across the brain. The metabolic ratios correlated well with fatigue. So lower, implying the lower creatine levels, the higher, the more severe fatigue. And it appears that creatine might be finally measured in absolute levels, significantly lower in some parts of the brain comparing to the normal people, but in some part of the brain, it appears to be higher. So this is the first study suggesting that different parts of the brain might respond differently to chronic fatigue syndrome, which is extremely important to address, particularly for the treatment options. So the location-specific variation in creatine metabolism might be a very important issue of the condition. Also, there is plenty of other important brain-specific responses to chronic fatigue syndrome, including the neuroinflammation, mitochondrial dysfunction in general, or also poor or aberrant neural communication. Urine biomarkers were also evaluated in people with chronic fatigue syndrome, and this is the first time we found out that some biomarkers related to creatine metabolism might be compromised in this condition. Here we evaluated, researchers evaluated 80 patients with fibromyalgia. Fibromyalgia is not exactly the chronic fatigue syndrome, but very similar conditions. Some people actually consider these two conditions as the same one. We find an elevated creatine excretion in this study via urine, creatine urine loss correlating very well with fatigue and pain severity, suggesting that you are losing more creatine from your body, and likely that is the reason why you're feeling more fatigue and pain appears to be severe. And also the authors of this study recognized, developing a unique algorithm, 3 specific metabolites, succinic acid, taurine, and for the first time, creatine, as very important in having diagnostic accuracy for this condition. This is the first time that creatine has been recognized. Okay, this metabolite might be a critical one, particularly for pain and fatigue. We are not talking still about a chronic fatigue syndrome. It's a little bit different, but still important. The metabolomics analysis, particularly from UK Biobank data, also revealed a possible role of creatine as an individual metabolite in chronic fatigue syndrome. We found out here the elevated urinary creatine, the decreased serum glycine, which might suggest increased utilization of creatine in chronic fatigue syndrome. And creatinine has been recognized among the metabolites that should be analyzed further in forthcoming studies and possibly correlate the level of these metabolites with the specific clinical features, including the signs and symptoms of chronic fatigue syndrome. Again, an interesting study conducted in the dawn of the long COVID back in 2023. Many choline-related metabolites and also players in methylation reactions across the human body has been found out in this study, and they are reduced in severe COVID-19 infection, the people who are going to experience long COVID a few months afterwards, suggesting that might be a dysregulation in metal donors. Here you could see specifically creatine and creatinine indicated as possible players in this story. Non-survivors had higher levels of creatine and creatinine, some other important biomarkers indicating liver and kidney dysfunction, but maybe overconsumption of creatine and creatine for this specific condition. And this is something that I'm particularly proud of because it's coming from my lab, and some people from my lab doing this research are around here. Today, we actually evaluated the level of creatine across the body in 90 patients with long COVID, and we compared the level of creatine in the muscle, in the thalamus, and the white matter and gray matter across the brain, and find out that at every single location, the level of creatine appears to be lower, significantly lower comparing to the normal reference level. But this is not the end of the story. There is a significant association between the creatine level and myalgia, suggesting that those people who have lower muscle creatine levels have higher level of more severe myalgia in long COVID patients, clearly linking the lower creatine levels with a more severe disease. Another study coming from my lab pay attention to a little bit more locations across the brain. It's actually 8 different locations. You could see the locations here. And we evaluated 81 individuals, 45 males and 36 females, who are recovering from COVID-19 after the end of the acute phase of the infection. And we classified them into the mild, moderate, and severe groups, analyzed many different compounds in the brain, including the creatine, but not only the creatine, and acetyl aspartate was also very interesting and important. We find out that not just the ratios, but also the absolute level of creatine across the different brain locations was lower in people who have more severe conditions. And it happens in 6 out of 8 different locations studied in the study. You could see here the significant differences between the mild, moderate and mild severe. So both the moderate and severe types of long COVID have a significantly lower levels comparing to the people who have only a mild long COVID. This led us to conclude that creatine depletion might be a metabolic footprint, another maybe new, but for us, as a research community, very important addition to analysis of different biomarkers in long COVID. So depletion might be a metabolic footprint of long COVID. And particularly that might be important for us as a community to replenish creatine, because people are not going to get easily a lot of creatine coming from the food, so they have to replenish it by supplementation and perhaps provide it as a possible strategy to correct the deficit. I'm not saying that this is the cause, of course, but this is probably something that should be addressed a little bit further. And maybe we could help relieve patients with their different problems, including the fatigue or pain or brain fog, if we administer creatine to them. Analyzing the nutritional approaches for people from long COVID, it's really interesting that it's extremely hard to find any official guidelines. This is the only officially recognized guidelines by some professional association offering to people from long COVID. It comes from the British Association of Dietitians, or BDA, and also in collaboration with the ME Association of Myalgic Encephalitis Association, which is really, really general. You could see it here. It's basically a Mediterranean diet without any specific advice how to tackle problems that are very unique and specific in people who are suffering from chronic fatigue syndrome. I'm sure in this room many people actually have chronic fatigue syndrome. Some of them might be aware of it and some not. But you're going to get this kind of general advice. It's not really a big deal. If you go a little bit deep into these guidelines, again, this is the only one, at least in my knowledge, you're going to get some information about energy, micronutrients and stuff like that, the importance to provide a lot of energy, but it's just a general guidelines, no specifics, nothing. You could learn more about that in this link, and this is the only one. Probably the leading authority in the world in terms of clinical nutrition is the European Society of Clinical Nutrition, and we presented at their conferences a couple of years ago many information about creatine and long COVID. I'm going to that a little bit in a few moments. But they didn't provide any advice for long COVID. The only advice this leading authority is providing is for COVID. And this is the document published 5 years ago, how people with COVID should be treated. And this is, again, a general clinical nutrition agenda, how to analyze and treat the people who are suffering from COVID. But in terms of long COVID, no guidelines. No guidelines as well from the American societies. I'm a member of a couple of societies in the United States, but there is no guidelines. But there is something interesting here in Aspen guidelines. They suggest that oral nutritional supplements should be considered and used and tested and, of course, scrutinized for a possibility to, include this as a part of the treatment for long COVID. but without addressing any specific, providing any specific advice about this. So how about creatine? Does anybody do any kind of studies in the past regarding the creatine? It is only a handful of studies, and most of these studies are actually coming in the past 5 years. The first one has been conducted approximately 23 years ago from Netherlands. It was a very small study in terms of the number of patients, 27 patients and 26 controls. It was double-blind randomized clinical trial, but you could see here, it was a multi-component product. So I'm not sure this is a perfect one, but this is the first one. And only 1.2 grams, so probably enough for somebody who is consuming a plenty of meat, you know, but it's not really a real-life situation for creatine supplementation. They provided a supplement for 10 weeks to this population, and they evaluated the fatigue severity, clinical symptoms of physical activity. But most of the outcomes are either patient-reported or clinician-reported, so very few are objectively measured outcomes. And we find out here no differences. Placebo versus creatine appears to don't bring any kind of benefits, summarized in this table. So a little bit more people from creatine group improved, not significant, but also make worse as well. So this is not really a good example of an excellent study in terms of the design, and there is a plenty of limitations. They didn't assess nutritional status prior to the treatment. Contrasting mixture components, so many different compounds, I think more than 20 different compounds were involved in the designing this, and I think this dosage appears to be comprehensively lower. Bruno group did a very nice study. It's in fibromyalgia, but still it's, I think, a right place today to discuss this one. They provided 20 grams of creatine for the first 5 days, followed by 5 grams per day throughout the study that lasted 16 weeks. It was a RCT as well. They measured the muscle performance, cognitive function, sleep, and tissue metabolism. Definitely, we could see here the improvement in the level of creatine after the end of the intervention for this population. So the muscle levels of PCR were higher, and also some other indices appears to be improved, such as the health-related quality of life domain, specifically mental health, appears to be improved after the end of the intervention, and also muscular performance in terms of dynamic and isometric muscular strength, and a memory also improved after the end of the study. My group conducted the study back in almost 10 years, actually, to 2016. We provided a bunch of women with chronic fatigue syndrome, a creatine precursor, or GAA. We provided it in a dosage of 2.4 grams per day, sole GAA without creatine, and intervention period was about 12 weeks. And as well as in Bruno's group did with fibromyalgia, we noticed an improvement in the level of creatine in the muscle, but it was also accompanied by the increase in some other exercise performance outcomes, such as the improvement in muscular strength, as well as the endurance capacity. And we also noted the improvement in some domains of fatigue, particularly for the mental fatigue, as well as the motivation activity. As well as in Bruno's group we also noted an improvement in some outcomes for 36SF tool related with physical and mental health domains. But we didn't find the improvement in the primary outcome set out for this study. It was a general fatigue. And then comes the COVID-19 pandemics, and we are all locked down, you know, thinking what will be the next, for the next week or the next year. You remember that time as well, having much more time to write. You know, I produced double number of papers for that year, mostly writing letters to the journal editors about different topics, you know. But we started some studies with long COVID patients, and this is the picture, and actually a news from my lab page. You could see here masks and stuff. We started back in October 2021 doing the first studies with creatine supplementation, creatine monohydrate supplementation for long COVID patients, analyzing different outcomes such as functional performance, level of creatine in the muscle and across the brain, many different locations in the brain, but also clinical outcomes, you know, how people respond, because being a medical doctor, it's sometimes for me it's very important to understand, not really to understand what is happening in the body, but if people are feeling better, that's good enough, you know. Sometimes it's not really critically important to understand the mechanism. So we try to embrace a lot of different aspects, and in the meantime we published 3 studies. So I'm going to dig a little bit deep into these studies to see what we find out. The first one was actually conducted with 12 patients, and we monitored them. It was a randomized controlled trial. We monitored them for 6 months, and we did in the middle of the study, after 3 months, we also evaluated the outcomes. So we supplemented people with fairly low dosage of creatine, comparing to other studies with creatine monohydrate for brain conditions that usually embrace much higher amounts of creatine, 20 grams, 25 grams, 30 grams. So we didn't expect a lot, but we actually get a lot of interesting results here. You could see here that different locations evaluated in our study, both after 3 months and after a 6-month follow-up, actually we find out significantly higher levels of creatine comparing to the control group. Not just in the muscle, but also across the brain. But besides that, almost all locations of brain tended to be increased. The study sample was quite small, so if we had a luck to recruit more people, it might actually end up with a statistical significance for much more locations. We didn't find out a lot about the fatigue evaluated in MFI 20 tool, which is probably not the perfect way how to do it, but most of the studies use this type of tool. No differences in time to exhaustion, but look here, all the clinical outcomes evaluated with visual analog scale, including the anosmia, ageusia, breathing difficulties, lung pain, body aches, headache, difficulties concentrating, all were improved in this creatine group. So it was really nice to see you could help people with long COVID, providing a comparatively lower creatine dosage, 4 grams, which is doable for regular people. And you could see here the side effects. Most of the effects are above of the range of 0.8, suggesting these effects might be large, particularly for the clinical outcomes, even after 3 months of administration. So it was very, very promising to conduct another study to confirm the results. And we did it in another study, providing, again, 4 grams of creatine monohydrate, but this time we would like to see it as adjunct treatment. So one group received a breathing exercise, which has been suggested from the European Respiratory Society as an alternative treatment for long COVID patients. So, okay, let's compare that with breathing exercises along with creatine. And more or less, we analyzed the similar parameters here. We recruited 8 people for this study. And you could see here that breathing exercise plus creatine outcompeted breathing exercise only for superior levels of creatine in different locations across the brain, and also improve some of the symptoms, particularly post-exertional malaise, meaning these people are feeling less fatigue after doing the minimal kind of exercise. We didn't find much differences in different fatigue subdomains evaluated with multidimensional fatigue inventory. So, okay, this looks even better. So at least 2 studies confirmed the positive effects, and we conducted a third one. Now we provided some extra amount of creatine, this time 8 grams of creatine in 50 patients suffering from long COVID, and we separated them in 3 groups, 1 creatine only, 1 creatine with addition of glucose, because we all know that glucose can help to get higher levels of creatine across the body from the circulation to the muscle, even to the brain, and we compare it with the control group that consume glucose by itself. We didn't find a big difference between creatine on its own and creatine plus glucose. The effects were quite similar. So if you're going to give it, it's up to you. Is it going to be consumed on its own or along with creatine? But still, we definitely see it's much better than glucose by itself to increase the level of creatine in the brain. So another interesting stuff suggesting that the range of creatine administration might be really different from very low dosages, such as 4 grams up to 8 grams, you're good. It was really interesting. When we published that paper, the first one, it was about 1.5 years. I've been called, this is the first time in my career, so many different medias. This is just a list of medias that approached me to give a kind of comment or interview about this, and people are next are talking about that. And a couple of weeks ago, I gave an interview to Daily Mail from the UK about creatine and long COVID and stuff like that, you know. And of course, this is very important for the research community to outreach for the people, but I always like to highlight the limitations of our study, you know, because people should not be misinformed by the researchers. You know, this is not a cure for long COVID, but it might help some people, definitely. So I always like, next to this, you know, sexy media stuff and altmetrics score, we did it in the small sizes, in a single lab. We are not able to evaluate the gender differences here. And you notice already that it might be a difference in terms of creatine metabolism between the genders. Even in long COVID, you already know about that for the general population, but even in long COVID, there is a difference. What about other populations? We just have some anecdotal data about the differences between the kids and adults in terms of long COVID and in response to creatine supplementation. We didn't address that. And people who have mild disease, we evaluated people with moderate to severe disease. We don't know what's happened with the mild disease, so they might not respond well to creatine, and they might respond even better to creatine. And we are not talking about people who are in the hospital because of long COVID, so who had the highest level or most severe conditions. And this is also interesting. We didn't account from the creatine intake from the diet. I'm going to talk a lot about the creatine from the diet tomorrow, so I invite you to be there because it's going to be totally different comparing to this clinical approach. But I'm aware that many people are not consuming a lot of the creatine from the diet. So if you're not going enough, you might be even better responding to creatine and having long COVID. And also, we didn't assess the level of habitual physical activity, not to mention the mechanisms. Plenty of mechanisms are implicable. It was really nice to see that another group recently confirmed our results. This is a study conducted in Poland, I think, a few months ago. Although it's not an RCT like our studies, it was an open label study, and they evaluated 14 participants. They provided even more creatine for a little bit shorter period of time, so 16 grams of creatine monohydrate for 6 weeks. They use a better system that we use. We use 1.5 Tesla, and here you could see 3 Tesla for this study. And they evaluated in anterior cingulate cortex and also prefrontal cortex, dorsolateral prefrontal cortex, so only this frontal part of the brain. And they also evaluated some symptoms, cognition using Stroop test and hand grip strength assessment. And like us, this lab also confirmed the superiority of creatine because at the follow-up, creatine increased the level of concentration in both locations. Here, statistically significant with large effect sizes here. They also noticed the decrease in fatigue and reaction time. They also noticed and highlighted the improvement of strength. And they find again correlation between increases in creatine and changes in reaction time, again suggesting that it's depend, again, the level might be related to the severity of condition. And this is not directly studied with creatine intervention, but you're going to be quite surprised that creatine in the brain might be by itself target for different nutritional interventions. This is a study conducted by my lab. We provided symbiotic, supported by DSM. By the way, again, a randomized controlled trial here. We provided symbiotic mixture during the 3-month intervention period in people with long COVID here. So no creatine in the formulation. It's probiotic and prebiotic. And it appears that symbiotic was superior to placebo to affect the post-exercise malaise. But it's really interesting that symbiotic also outcompeted placebo in terms of creatine levels in the brain. And you could see here, particularly for the left frontal, both white matter and gray matter, symbiotic improved the level of creatine in the brain and decreased the severity of the condition, suggesting that brain creatine might be, and I think should be, considered as a therapeutical target in long COVID patients. So our interventions should focus to creatine, which is, I think, a pretty big deal for our community. And this is the typical location of voxels analyzed in the studies we are doing in my lab. Before concluding the presentation, just one slide on possible mechanisms. I provided this in previous Congress, but I expanded a little bit because we get some extra information. We, of course, know this might be the most important mechanism how creatine works in long COVID, facilitation of ATP recycling, but there is plenty of other possibilities, including the antioxidant, toll-like protein-related processes with inflammation suppression or stimulation immune response, affecting GABA and glutamate receptors through the glutamatergic modulation might also be a reason how creatine might help people with long COVID, as well as mitochondrial permeability transition poor that might be also improved or affected as a component of neuroprotection with creatine supplementation. But this is something that I added a couple of weeks ago. We have some preliminary information about the possibility that creatine in the brain can also affect endothelial function and improve the brain oxygenation. Also, it might affect iron redox dysregulation, and this is very, very new. It might even affect the amyloid beta accumulation, which is not really convenient and very popular biomarker in long COVID, but there is a link between the amyloid beta accumulation or at least dysregulation in long COVID, so creatine might tackle that as well. So many question marks here, and in a particular, I'm not sure what is the, of course, what is the contribution of each of these mechanisms to the final beneficial effects of creatine for long COVID. So open questions, plenty of them, definitely. The most important one on the side of the diagnostics and biomarkers, is it a creatine really a good biomarker in urine, in brain, in heart, or muscle, or a circulation? Is it a good indicator of a long COVID? There is definitely possibility for creatine deficiency in a long COVID, but it might be affected by age, gender, also ethnicity, comorbidities, disease severity, and this is something that has been suggested, and I think pretty smart by one of the reviewers. Have you considered the vaccination? We didn't. It might be a player, particularly affecting the immunity, and creatine having a role in immunity might be a relevant issue. And of course, this is also important, not just in terms of tissue-specific brain versus muscle, but also keep in mind that it might be different across the brain. It might be location-specific. What would be the interventional protocol? Open questions are plenty of them. There is a plenty of different dosage regimes, like we suggested. The first study, started with 1 gram of creatine up to the 20 grams. So this is a huge window of opportunities, and we don't really know what appears to be the perfect, but we find out that even the small dosages, 4 grams or more, might be very, very effective. And what is the perfect duration? Probably the longer, the better, but at least 3 months, in my opinion. We don't know a lot about the mechanisms or contribution of each mechanisms. And of course, what is the perfect formulation? Creatine monohydrate has been evaluated exclusively for the recent studies with some other also opportunities evaluated earlier, particularly creatine precursor. To conclude here, this is a nice paper published recently analyzing, different precision in nutrition, which is a fancy, sexy word these days. What would be the perfect way how to address people suffering from long COVID from the metabolic perspective? Very nice picture. These days with artificial intelligence, you can get much better pictures than back in the day, but I trust more the old science, than these fancy pictures. But this is nice to see. Creatine has been listed here among other interesting molecules that might be relevant and important. So I can see a kind of stimulus to many different groups across the world to validate our findings and continue doing good work on chronic fatigue syndrome, because it's not just COVID pandemics stuff. So take-home message, definitely very mysterious, perplexing, unknown, under-evaluated condition, neurological condition. We don't have a gold standards to evaluate it, and creatine might be considered as a metabolic footprint of chronic fatigue syndrome. We have some preliminary information that impaired creatine metabolism accompanies chronic fatigue syndrome. Need more data to confirm that, not just in a muscle, but also in other tissues. Pilot studies suggested that creatine might be very effective in tackling these conditions. Anecdotally, I often give creatine to my patients, and they're feeling better, really. So it's a placebo or not, I'm not sure, but this is something that should be highlighted here. Lower dosages are effective as compared to other neurological conditions. And I commented that on a paper that is related with this presentation. And I discussed a lot why this is happening. It might be due to the fact that actually the long COVID brain is different and allows more creatine easily comparing to normal brain to be uptaken. Or for instance, creatine is going through different channels in the long COVID brain. Or maybe there is an endogenous production of creatine in the brain. Or maybe less elimination of creatine from the brain into the circulation and out of the organism, and many, many others, including the unknown mechanisms. Several supplementation protocols are available at this moment. We don't really know about the definite mechanisms, but like almost every single study or any single presentation, always like this, more studies are needed all the time, and particularly this might be the very important population to address. So the final slide, just to acknowledge the help of the big team I'm leading in 3 different institutions, University of Pécs in Hungary, but mainly University of Agder in southern Norway, and Applied Biogetics Lab. And I invite you guys to visit my PhDs and postdocs. We are presenting 5 presentations at this conference. Thank you very much for your attention.